money. So if we look at dementia as an overview, first I will say that this has not only happened to older people, okay? I just had a patient here at the hospital that is 51 years old with a form of dementia. I see patients in their 40s. So it's not something that we just see the older population have. But when we do form a dementia, we have to look at, it doesn't only impact memory. And if I go back to the cancer analogy, and I want you to think about cancer as this umbrella. And underneath this umbrella of cancer, we have Hutchings lymphoma, we have brain cancer, lung cancer, all these different kind of cancers that fall under that umbrella. Well, think about dementia as the same thing. So underneath the umbrella of Alzheimer's, underneath the umbrella of dementia, we have Alzheimer's as one type. There's other types of Alzheimer's, and then we have different forms that I'll talk about here in just a little bit. So think about dementia as if somebody said somebody has lung cancer, it would be the same as Alzheimer's dementia. But dementia doesn't only impact a person's memory. I had a patient one time give me probably the best definition I've ever heard when it came down to defining dementia. And I have all these different textbooks and all this stuff that doesn't mean anything. But this lady just looked at me and said, Dr. Hutchings, I don't feel like myself anymore. And it's a change in personality. You see a change. Of course, you have the memory issues. You see the paranoia. We certainly see a lot of paranoia about money. We see hoarding behaviors. I had somebody today that was a hoarding individual. We see, getting, maybe it's cooking recipes or problem solving. We see these higher level brain cognitive skills begin to deteriorate a little bit. But we also see impairments in walking. And some of those are actually some of the earliest clinical symptoms of dementia, some gait or walking problems. So think about it as a piece, as a diagnosis that impacts all mental and physical functions and not just the memory piece. And I want to urge that dementia is not a part of the normal aging process. We don't just get older and develop dementia. It is a genetic mutation that is not always hereditary, and it's not just a part of the normal aging process. As we get older, we may have some slower processing, some minor memory issues, but dementia itself is not a part of the normal aging process at all. So when we look at dementia, remember, this is the umbrella, okay? And we have many different types of dementia that fall under that. But before I diagnose somebody of having an actual dementia, I want to rule out other things. And these are things that you can bring to your doctor. And if a person's having memory issues, maybe we need to check their thyroid to see if there's any vitamin B12 insufficiency or any thyroid issues. That can certainly cause memory issues. The D in the word dementia stands for depression or drugs. I can't tell you countless patients I've had that have been on many medications that are causing this person to have memory issues. I had a lady not too long ago that had rheumatoid arthritis, and she was on a ton of pain medications. And I realized, like, this lady does not have Alzheimer's. She has too many medications. And once we got her off some of that, her memory started to improve. It could be a metabolic issue. It could be epilepsy. It could be poor nutrition. It could be toxicity. So if a patient maybe has had multiple surgeries and they've had multiple anesthesia, that certainly can cause some memory issues. If a person has a cardiovascular history, this leads us into another different type of dementia. Or it could be more structural or more trauma related. So when we look at the word dementia, before I give somebody this diagnosis, I want to walk through these things and make sure that it's not depression, it's not their thyroid, it's not different things before we say, hey, this person has a progressive neurological condition. So if we look at a little bit more on the dementia overview, we basically look at it in we go through some testing, some neurocognitive testing, which I'll talk about here in just a bit. But we also do imaging. And on the imaging, if we do an MRI, we look for some cortical atrophy. And that just means that the brain has shrunk compared to like a normal sized brain. And I'll explain why that happens here in just a little bit. But just to kind of a precursor to the staging. Just as we stage cancer on a 0 to 4 scale, we stage dementia patients on a 0 to 7, 0 being normal and 7 being profound. Well, we have what we call pre-dementia. I don't necessarily like that term, but that's right in the stage 3 realm of that scale. And we do have a lot of patients, a high percentage of patients that develop dementia that have mild cognitive impairment. But mild cognitive impairment patients are very well aware. They're very high functioning. They can still keep up with their checkbook. They can do a lot of things that most people with cognitive impairments can't, but it's very, very, very mild. So if a patient does have MCI, kind of going back to that last slide, I'm looking at other things to make sure that this is, is this pointing in the direction of dementia, or is this pointing in the direction of something that's actually very fixable? And it sounds crazy that I can say that most dementias are fixable. Most of them are not progressive. And so when we make that diagnosis, we have to be very, very sure that's exactly what it is and what it's turning into. But knowing that stage is very critical because it's going to help you keep ahead of the disease process. I can literally stage a person and give a family member a timeline, not only of how the disease will progress, but what's coming next. So if a person is living at home, it's very critical we have staging, because that we can say, okay, at this point we may need assisted living, or at this point we're going to need more advanced care, maybe it's memory care or whatever that may be. Some of the things that we see versus normal aging versus an actual dementia. This slide here is a little bit out of order because I see difficulty handling money or paranoia with money first. So if any of your loved ones are having a lot of paranoia with money or just paranoia in general, frequently asking the same questions over and over, having difficulty scheduling their appointments or keeping up with appointments, or just having difficulty kind of learning new things, you're having memory lapses, these are not things a part of the normal aging process. I would imagine everybody on this webinar has probably walked into a room maybe and forget why you walked in there. And that's normal, as long as you can remember at some point why you did. Because the brain, again, is this computer that God has given us that is that begins to slow down a little bit as we age. But if we're seeing some of these symptoms here, these are definitely things you want to talk to your doctor about and go and say, listen, Dr. Smith, my mom has been having issues she's been having paranoia about money. She's having some sleep issues. She's having, she's repeating questions over and over and over. She gets irritated. She has high anxiety. Bring these things up to your doctor, because these are all things that are going to cue them to think, okay, this is something that can be a little bit more than just the normal aging process. So if we look underneath that umbrella of dementia, there's about 85 different things that can cause a person to have dementia. But the question is, what do they all have in common? Number one, yes, they have memory issues. So they will have some of the short-term memory issues. The next is actually what we call aphasia. And this is something you also would need to look back on your family members and what to talk to your doctors about, because many times patients will have word finding problems. I had a lady this morning that literally could not think of a word for anything. And the reason this is because there is a filing cabinet of all the words that you know in your brain. And I'm using that filing cabinet right now. I'm opening up the drawer. I'm pulling out words to put them into a sentence to convey an idea to you. That filing cabinet is very close to that short-term area memory of the brain. So many times patients will have trouble finding words, or they'll use the wrong word in a sentence, or maybe they may even have a whole paragraph they could have summarized by using just one word. So they're forgetting words. That's something that is very characteristic. But at the same time, the ability to understand speech, which is what you're doing now, is actually housed very close to our long-term memory areas of the brain. So that's actually preserved for quite some time. So even if a patient's having extreme difficulty speaking, it doesn't, excuse me, it doesn't mean they can't understand speech. The next thing is the motor and the physical piece of this. And so we have what we call a condition called apraxia. And if you ever wanted to know what it feels like to have that, is to write a sentence or maybe your name with your non-dominant hand. So if you're right-handed, write your name out with your left hand, and that's what it would feel like to have apraxia. So think about it like as a cell phone, and your muscles has a cell phone, and your brain has a cell phone, and the cell phone signal between your brain and the muscles are disrupted. So we're going to have some movement issues. We're going to have some changes in gait. So you can see this is not only impacting our memory, it's also impacting our physical ability. They also have attention issues. And then one I want to point out here is agnosia. My father-in-law has Lewy body dementia, and there's many times that he doesn't recognize his wife. He recognizes me many times because I'm one of the physicians following him, but then he may not recognize my wife. And this is when a patient is having trouble recognizing a face. And so basically the brain is unable to attach a memory to that face. And so we call that agnosia. So they may get confused on who you are. It may come and go a little bit, but then also they may get confused on their actual environment of their home and not recognize their own home. So of all the different types of dementia that we have, this is what they certainly all have in common. When we look at the different types of dementia here, we don't have enough time today to really talk about all of them, but I want to talk about the most prevalent forms, that being Alzheimer's is at the top. We have vascular dementia, which is the second most common form of dementia. Then we have the Parkinsonian type dementias that I'll talk about. And then we have kind of more of a rare type group of dementias that are called frontal temporal lobe dementias. So I want to kind of outline these for you and give you some background on them, but also to have, again, to come to your doctor and say, these are the symptoms they're showing, could this be a vascular dementia or could this be an Alzheimer's dementia? Because it's critical, absolutely critical that we have to identify the type of dementia that a person has and the stage, because the medications that we use are different based on different types of dementia. So it's very critical that we understand what type. So let's start off with Alzheimer's disease. So we can get all technical here, and I don't want to do that, but basically the pathology behind Alzheimer's is that there are different types of Alzheimer's. There's what we call late onset Alzheimer's, and that just means that gene has mutated somewhere around the age of 80, okay? And then we have early onset, and that means that the gene is mutated late 60s, kind of in the early 70s range. And then we have the very rare forms that we have patients that are in their late 30s or in their 40s that are much more highly genetic. Late onset Alzheimer's disease is not always genetic in nature. But basically what happens here is that we've all heard of the plaques and the tangles. And so let me kind of explain this. So neurons in the brain love to talk back and forth. They love to communicate. Well, what happens in Alzheimer's is that there's a mutation of a couple different things. And when those mutations happen, the brain is no longer able to break down or digest fats in the brain. So it actually builds a plaque on the outside of the neurons. So no longer are we able to talk because now they have this plaque on them. So that's where you hear the plaques. But then you also hear about the tangles. So on the end of a neuron, it looks like a tail. And on this tail is basically a railroad track. And if you think about a railroad track, it has two parallel bars and it has perpendicular bars, where these perpendicular bars begin to deteriorate. So no longer does that tail of that neuron have any structure. So it begins to shift and it begins to tangle up. So there we have the plaques and the tangles, and that's what causes the brain to shrink, because those neurons are depleting, if you will, because of the plaques and the tangles. So these patients, many times, Alzheimer's patients will have very, very good long-term memory, but very poor short-term memory. So that's a characteristic that we would see. When we reach the age of 80, the chances of developing late onset Alzheimer's disease goes up by about 50%. But again, it's not always genetic. So I'll say that even if you have a history, so if you're looking at maybe your wife, for example, my wife is terrified she's going to develop Alzheimer's. So her dad has Lewy bodies, so she now has a gene for some form of dementia. So her chances go up by three times. But if her mom and dad both have dementias, then her chances go up by 12 times. However, that gene is the most prevalent in the Nigerian population, and the Nigerian population has some of the lowest prevalence of Alzheimer's. So what are they doing to combat this? How are they preventing this? And I published an article on this a couple of years ago, and basically sleep hygiene has a big part of it. You need to make sure that we're getting at least 6 to 7 hours of deep sleep per night. Following more of a Mediterranean type diet, if you can. I don't always practice what I preach. I love a good steak, so I'm not always practicing what I'm talking about, but trying the fish and the grains and the chicken, those things are certainly good for you. And I actually think a Mediterranean diet has a glass of red wine per day, so that's pretty good too. So that's good for your cardiovascular health. Making sure that we're not having big meals before we go to bed. Because whatever your belly has to digest, your brain has to digest those fats as well. We all think about physical exercise. That's a big one. It releases all kinds of good stuff in the brain. But we also need cognitive exercise. My wife is finishing up her PhD right now. She's trying to learn piano. She's using things in her brain. She's trying to use her brain in a way she's never used it before. So keeping your brain active. And this is one of the reasons that we saw the impacts of COVID so big, because we were socially isolating ourselves, and that impacted our brain activity as well. And you can see socialization is there. Depression, a high level of depression, and any kind of a lot of anxiety, any kind of psychosis that we have certainly can increase our risk as well. If you're smoking, I will say stop. Smoking increases heart disease, increases the risk of Alzheimer's and all that. And of course, maintaining a healthy weight, and then alcohol in moderation. So vascular dementia is one that's kind of near and dear to my heart. My stepfather has vascular dementia, and basically it's different than Alzheimer's. Many times these patients have a very shuffling type gait patterns. And then what I hear from families a lot is that it's very up and down. There's some days they are almost completely normal, and there's other days they're not. It's very, very, very fluctuating in nature. But let's just take if your loved one has high cholesterol, they have coronary artery disease, they have heart disease, they have a pacemaker, they've had a history of strokes. These would all be huge clinical indicators of a vascular dementia. These patients also have a hard time with sleep. A lot of times their sleep is very erratic, and we need to have sleep for memory. So sometimes, again, they can look like Parkinson's patients, but in fact, they have this cardiovascular history. And this form of dementia is what I kind of call the Tennessee highway. It's very up and down, very up and down. And then sometimes they'll be plateaued for a little while and have a quick little drop. So it's a lot different than Alzheimer's in terms of the progression. And then also, again, they have that history of that cardiovascular disease. And so this is a picture here of some imaging of what it would look like for a vascular dementia patient. You can see these little white specks all over the place here. And this is the vascular disease in the brain. And also you see, if you see this real spacing, kind of the dark area, it's real spaced out. Here you can see, that's the symptoms of the brain actually shrinking a little bit. So we start to see some of that atrophy or the shrinking of the brain because of the cardiovascular disease and the vascular dementia. So some of the things that you're going to see is definitely in vascular patients, they can have hallucinations. These are very treatable. They may have some dizziness. They certainly have the walking issues. Their personalities change a little bit. They definitely have some memory issues. Some patients will actually have crying for no reason or kind of spontaneously laughing. And then they'll have some confusion. But again, it's a very fluctuating up and down dementia. So if your loved one has that cardiovascular history and they're having sleep issues, hallucinations, they're having memory issues, this is something to go to your doctor and say, I feel like based on a seminar I heard that this could be vascular dementia. Can we maybe do some imaging and some further testing? So the two types of dementias that are associated with Parkinson's disease are very, very difficult to treat. You heard me say earlier that my father-in-law has Lewy body dementia, and I want to be very clear on this. If a patient has one of these dementias and we treat it like an Alzheimer's, we can actually make these patients worse. So the medications are critical, and I'm going to talk about those here in just a few minutes. But basically, Lewy body dementia is diagnosed primarily on, does a patient have memory issues and cognitive problems, and then they develop Parkinson's. If it's in that format, then we're dealing with a Lewy body dementia. If it's reversed, then the person had Parkinson's first, and then they developed more cognitive issues. This is what we call PDD, or Parkinson's with dementia. These patients have extreme hallucinations. My father-in-law actually is in this delusional state where he actually thinks he works for the governor and for the government. I had a person not too long ago that spent his entire life savings to decorate his entire room to make it look like Candyland, and that's what he saw, but it wasn't decorated as Candyland at all. That's his delusions. But also they have extreme insomnia issues as well. So we have to control the insomnia. We have to control the hallucinations. And so we have to do that very carefully because the medication regimen is quite a bit different. And then we have some of the more rare forms of frontal temporal lobe dementias. I am seeing these at much higher prevalence in my practice. And basically what this is we see the frontal portion of the brain, the front portion, and the side portion of the brain begin to deteriorate. And it's a much faster moving dementia, and one that has a shorter life expectancy, but there's different types. So if you think about the front part of your brain, it is like your social filter, okay? So some patients may have a behavioral variant where they are extremely inappropriate from a social standpoint. I had a guy the other day that got very aggressive with his wife and actually tried to choke his wife, and he didn't see that there was anything wrong with that. And so that is more of a frontal lobe issue. And then we have what we call semantic or temporal variant, and that's a language issue. So like I said earlier, we have these filing cabinets in our brain, right? Well, if I asked a patient with this form and I showed them maybe two pictures, one of a palm tree and then one of a Christmas tree, and said, which one do you see on the beach? They would be unable to determine which type that would be. And then we have primary progressive aphasia. And if any of you are dealing with this, it is a very difficult form of dementia. These patients actually have their memory preserved for quite some time, but they completely lose the ability to speak or even understand speech. So it would be like me going to France and I don't speak French. I wouldn't understand what's being said to me, and I wouldn't be able to speak. And so that's the dementia that actually impacts the language portions of the brain. And this is kind of what it would look like post-mortem. You can see the front part of the brain, again, all that spacing, a lot of shrinking there, and a lot of shrinking here in the side part of the brain. But the back part is okay, and the top parts look okay as well. But you can certainly see a lot of deterioration right there in the front part of the brain. So with all that being said, I went through that kind of fast just because the time, I want to make sure that we open up for having some questions. But now that we've answered the question of what type of dementia it is, let's talk about treatment and let's talk about staging. Now, first of all, sundowning. If your loved one is becoming more confused in the afternoon or evening, maybe they're getting combative, maybe they're getting agitated, maybe they're getting more confused. This is what we call sundowning. And I see this percentage of 66% of dementia patients have sundowning. I don't buy that. I think it's probably up in the 90s, to be quite honest with you. But basically sundowning, as I mentioned, is a patient literally almost at the same time during the day. It could be 2 o'clock, it could be 4 o'clock, 5 o'clock. They're going to have these symptoms. Partly because of that is because there are certain chemicals and hormones that are produced in the body that are not being produced as well when we have a dementia. But this is very, very, very treatable. So if I have a patient that is sundowning at 5 o'clock and they get very confused or combative, then I may give them a medication and actually give that to them at 4 o'clock. And that way this medication is going to start to kick in before that 5 o'clock period. So, and I'm going to talk about medications here in just a moment, but when you talk to your doctor and your loved one are experiencing sundowning, get them on a medication to decrease anxiety, but it needs to be given before the sundowning occurs. And it's actually, most of the time, it's a very easily fixed condition with the right medication and making sure that we're giving it at the right time. So the medications here that we treat memory with, I guarantee that if you're on this, you've heard of these medications. We have the Aricept, we have the Exelon, we have Namenda. These medications are designed to improve memory. I will tell you, I know this is being recorded, but I'll tell you, I'm not a big fan of these medicines. I think that they help for a very short amount of time. And when I talk about staging here in a moment, we typically see these medications not helping at all around stage 4.5. Remember, 7's profound and 0 is normal. So to me, that's just another pill to take. I'm more focused on controlling sleep, depression, anxiety, the paranoia. And, these are just another medication to take. So in rounds just a few minutes ago, I have a patient that's on stage 5.6. And I said, okay, we're going to discharge these medications because it's just another pill to take. And I'm a firm believer, the less the medications, the better. And if we're going to take something, let's make sure it's making the patient calm, not doped up, but calm, but also it's relieving some of the stress of the caregiver as well. So some of the medications that I do want you to think about here, and this is being recorded so you can go back and listen to this, but I'll be very clear, medications like Xanax are not good in dementia patients, not at all. In fact, if I took a Xanax, it would calm me down. And many times these patients that get a Xanax, it will hype them up. So it has the opposite effect. In the same drug class is a medication called Ativan. It can sometimes be okay to help, but I would not go, heavy on that medication. The medication called Seroquel is a very, 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 very safe medication to control the paranoia, to control the sundowning. Basically, Seroquel, I'll use it because I can decrease anxiety, I can help the sleep, and I can also help with the sundowning all with one pill. So Seroquel is a very, very safe medication to use. And then we have other medications that if a patient has like a bipolar or a very unstable mood, kind of up and down a lot, we may use different mood stabilizers for them. But if I'm describing something that you've seen with your loved ones, definitely consult with your physician about the use of Seroquel because it is something that's very, very helpful. For sleep issues, a medication that's called Trazodone is very safe as well in controlling sleep. If your doctor ever prescribes a medication called Ambien, don't take that for dementia patients because it can actually cause a lot of problems. So when we go for testing, here's some of the testing that I would like to outline. Your doctor more than likely is going to do a Minty Mental Status Exam or an MMSE. I don't like this test. I'm not a fan of it. I think it's been around since Adam and Eve ate the apple, and it doesn't really tell you much. But if you break down the numbers by function, the highest score you can have is a 30. So when we have a 25 or 20 to 25, this is where we're going to start to see keeping your appointments, managing your checkbook, manage your medications. We may see some walking issues. When we decline from there, from a 15 to a 20, we're going to see issues with dressing and bathing and grooming, using appliances in the home and just the safety in the home. So if they do a mini mental, the thing is that we get a score and that's fine, but what does that score mean? And that should be a question that you have to your doctor. What does this score mean in terms of, are they safe to be at home? Can they be left alone at home? These are questions that we should be having when we have these cognitive tests. So let me look at the staging process here so you can see this. This is, again, very, very critical because we have to stay ahead of this disease. We cannot get behind it. And if we have a stage and we know that this is the type of dementia we're dealing with, this is the stage that they are, it allows me to be able to know that, okay, I'm going to put this patient on Seroquel, but I'm going to be able to move these dosages up as they progress. And I can put a timeline. Many times families ask me, well, we only have so much money. Like, how long is this disease going to prolong? And I can give them somewhat of a ballpark, or I can say, hey, your next big decision is we need to look at assisted living, or we need caregivers, or if they're a 4.5, when we get to stage 5.0, we need memory care. So, it's very important to have the stage to be able to put a timeline together of how this is going to progress based on the type of dementia that a person has. And you can see that stage 5 here is more moderate dementia. This is where they need more 24-hour care. When we move into stage 6, in these stages is where we're going to start to see the patient have inability to really recognize you. So we know we're pretty far along in terms of the progression here. Stage 6 and stage 7 definitely have a lot more physical abnormalities, walking, feeding, those types of things, bathing, dressing, those types of symptoms that we would see. So it's 2:40 right now. I'm going to stop sharing my screen. I got a couple things I want to say real quick. Let me see here. Stop sharing. There we go. Okay. So I covered a lot with that, but my main point here to kind of summarize is, it's when you go and talk to your doctor, make sure that you are outlining what you're seeing. The paranoia with money, the change in personality, the short-term memory issues. And I don't want to hear a doctor say, oh, this is probably just old age, and pass it off, because many times it's not. And that puts us behind the disease process. Knowing the medications to ask them about. If they're having issues with sleep and paranoia, we don't want our loved ones to be depressed. We don't want them to be anxious. We want to make sure they're sleeping. We want them comfortable in making sure they're on the right medication regimen that makes sense for now, but also makes sense as they progress as well. And I share this in a lot of my lectures. I know Cheryl is on with Alzheimer's of Tennessee, and she knows this about me. My sister at 43 developed dementia, and we were part of the caregiving process, and I learned a lot in terms of caregiving, but also it taught me to be a better doctor in not only treating the conditions, but spending time with the families, because I know exactly what they've gone through or what they're going through. You don't wish this journey upon anybody, but it is critical for us to understand these are the types of dementia. There are different stages, and there are many different medications that can decrease caregiver burden, but also make that patient much more relaxed and comfortable, and not feel so anxious or not have depression. Because I don't think I've ever seen a dementia patient that didn't have some type of anxiety or depression. So we have to make sure that we're treating dementia, whatever type that is, and also the anxiety and the depression itself. I always feel like I have two patients. I have the caregiver and the patient themselves. And we have to make sure that you're taking care of yourself as a caregiver, but also knowing what to ask your physician, knowing what to bring to them before that appointment, so we can not get behind the disease, but certainly get more in front of it and allow us to have more of a plan of care that's going to help this patient throughout that disease process. So I'm going to start opening it up for questions, if that's okay, Kanita, if you don't mind. And hopefully we can get to some questions before the 3 o'clock hour rolls around here.
Yes, that's perfectly fine. If anybody has any questions, feel free to unmute yourself and ask your question, or if you want to type it in the chat box and I can read it, that's fine as well. So whatever everybody wants to do. And thank you so much. Mary has her hand up. You're on mute.
Oh, I think Mary's still on mute there.
Yeah, I'm trying to. Can you unmute yourself?
Sorry.
There you go.
Okay, I'm sorry. Now this is Ed. My wife is Mary, who does have dementia. In 2017, she developed severe anxiety, then mild dementia symptoms, and then after some memory loss, after a year or so, she did develop tremors. She does carry a dual diagnosis of Alzheimer's and Lewy body syndrome. And that's leading up to my question, because she does the, right now what I'm seeing is more Lewy body, more hallucinations, disorientation, etc. Of course, she does have some short-term memory loss. But her medication, she does take Aricept, she does take Namenda, and she is taking a medication, I'm not sure which one right now, for tremors, but it is working.
Okay.
What I'm really concerned about is she's taking buspirone, she's taking a couple of other medications. One of them, she's taking amitriptyline to handle anxiety. And I know that interferes with serotonin uptake. And I'm concerned, but we took her off that, but the anxiety became almost paralyzing. So I'm really concerned about the medication that could be best used to control her anxiety.
Absolutely. Great question. And so I would say that Alzheimer's does not go with Lewy body. So she probably just has the Lewy body dementia itself. So, first of all, I would say that, for her, if it was my patient, I would have to agree with you. The hallucinations are something we can deal with later on, but I would certainly want to address the anxiety more than anything. So I was talking about Seroquel earlier. Seroquel, we usually start that off at 25 milligrams. And so we can give it more than once a day. We can give it 3 times a day. But basically, I would try to figure out, is she anxious throughout the entire day? If so, then we need to start her on the Seroquel and then have her on multiple dosage a day, probably 2 to 3. But also what I would do, since it is a Lewy body case, is I would make sure that we would have a Seroquel dosage about an hour or so before she goes to bed. And that's going to help her sleep as well. And I'm glad you bring this up, because there is a medicine that I hate, and that's called risperidone. Risperidone, and this is what happened to my father-in-law with Lewy body. They had him diagnosed with Alzheimer's. They put him on risperidone, but the side effects of risperidone causes Parkinsonians. So now you have a medication that's causing Parkinson's, and then you have a Parkinson's dementia. So long-winded, I would say, I would definitely ask your doctor about Seroquel. That is the safest medication to control anxiety and paranoia, sleep in your Lewy body patients. So I would certainly ask him about the Seroquel for sure.
Thank you. Thank you.
Very, very good question.
Does anybody else have any questions? Comments?
think we have one in the chat box here.
Yes, it says, I think my mother may have beginning stage of dementia. She just asks questions over and over. When I ask about going to the doctor with her about it to see if she needs any meds, she gets defensive. How do I get her to talk to her doctor about it? Great question.
Yeah, it happens all the time. And I get it. I get it. I mean, some patients get really defensive about it. I would actually, there's a couple things we can do right here. I would, number one, talk to the doctor before she goes. And then we can certainly get her on some medicine, whether it's for her memory or whatever you feel like is the biggest thing. Is it like, the previous question, is it more anxiety or is she depressed, whatever it may be. And then we just stay away from talking about memory, and we stay away from the big A word, Alzheimer's. We stay away from the dementia word. And we can just gear this as to, hey, we're taking, this is a new medication. It's going to help you for your heart. This is a new medication. It's going to help you with, whatever it may be. But I would stay away from those terms, but have a conversation with your doctor or the doctor's nurse prior to the visit. Say, this is what's going on. She's defensive, but here's the problems that we're having. In a patient like that, I would never even mention dementia because it's going to make everything worse. So I would certainly try to talk to the doctor prior to the visit and stay away from using any kind of terminology that reverts back to the Alzheimer's. I saw another one here. Did you mention earlier the Nigerians have a higher rate of the gene, yet the higher rate? So yeah, so the Nigerian population has the highest prevalence of the Alzheimer's gene, but some of the lowest prevalence of Alzheimer's. Good question. Okay, let me see if there's any more questions here in the chat box here.
There's one. It says, in rural areas of Tennessee, there are fewer resources. Any ideas how to help these families?
Yes, I can. I can help you. If you can get on Zoom, we can do telehealth. So I'm trying to, branch out. I do a lot of telehealth visits across the country with patients. So I'm more than happy to and I know that the Alzheimer's Tennessee does that as well. So in terms of seeing a doctor, being assessed, I can help you with that. But I certainly would reach out to Alzheimer's Tennessee as well, because they offer a lot of great resources for families. And they can kind of walk you through, and they're kind of the hub for sure for supporting families in education. Yeah, good job, son. Yes. Okay, yes. He said, very interesting to know my family is Nigerian. So that highlights with me. So good. You have a good group here, Kanita.
Yes, we have a great group. We always have a good turnout. So, and everyone heard you were presenting, so everybody wanted to join in.
Also, I'll say that if you are interested in getting an appointment with me, that's fine. Blue Sky House Calls is who I practice with. So let me and they're out of Nashville. So let me give you their phone number real quick, and I'll put that in the chat box.
Okay, there was something that just popped up in the chat box, and I'll read it really quick. It says, our mother is a nursing home resident. She has to have assistance for all her ADLs. She no longer walks. Now she is sleeping almost all the time. She is on a puree diet, and it is becoming more and more difficult to feed her because she doesn't wake up. And
615-340.
6840. Yep, that's the number to my office. Yes, ma'am.
so it says it's becoming difficult to feed her because she doesn't wake up and she forgets to swallow. Do we just let her go?
There are different treatments out there from the swallowing standpoint. If she's forgetting to swallow, my thing is that I would definitely call in speech pathology to take a look at her. They probably already have, but I would say that looking at different temperatures, hot food, cold food, maybe more sweeter foods. Those types of things can help stimulate the senses and help increase the swallowing. It certainly sounds like your mom is quite possibly in the later 6 stages if we're having some swallowing issues. But I think that Fran brings up a really, really good point, is that if patients are starting to lose weight and stop eating, please don't think that they're starving, because they're not. The brain is actually releasing a lot of great chemicals and endorphin, basically to kind of relax the patient. So it's almost like a euphoric state for them. But I certainly, don't want the patient to get pneumonia either. So I would assume having speech pathologists take a look at them, but also if they're at a point where they're losing a lot of weight, then that's something that I would certainly look at more hospice for. And I'm a huge fan of hospice.
Dr. Compton, I think you have a question.
I did. Dr. Hutchings, good afternoon. Thank you for the presentation. As usual, it's excellent. I want to circle back to your comments about mild cognitive impairment. When do you personally go ahead and start the acetylcholinesterase inhibitors, or like Aricept or dinospril, or when you use another drug, Namenda? When do you start those drugs, and when you personally make the diagnosis of MCI in an individual?
Yeah, so that's great question. So if I have a patient I'm testing, and going back to the staging for everybody, if again, 0 is normal, 7 is profound. If I have a patient like 2.6, 2.7, like kind of coming into that MCI, that's where I'll start saying, okay, let's look at the cholinesterase inhibitors, like the Aricept, the Namendas, all that kind of stuff. And then once we get to stage 4.5, that's when I say, we don't need them anymore. So if I try to see a patient before the MCI, but they're coming into MCI, that's when I feel like we should start those, and then definitely keep them on them all the way through the MCI. Because I mean, they do work for a certain period of time. But once we get kind of mid 4, then I'm thinking, okay, they're not really doing anything anymore. And to be honest with you, doctor, I have never seen titrating my patients off that. I never see any difference whatsoever. And then on top of that, some of them, like Namenda, for example, can cause some dizziness. So back to the other question of the gentleman with Lewy body, with the wife that has Lewy body, I would be careful, keeping them on Namenda for a long period of time, because it can cause some dizziness and increase some of the fall risk.
Thank you.
Yeah, great question. Good to have you on, Doc. I saw you nodding your head, by the way, when I was talking about the benzodiazepines. And I was like, it's good to hear. We all don't like Xanax in dementia patients.
All right, we have a couple more things in the chat. Hannah said, not a question, but a comment. I'm a program coordinator for a music program that offers music to residents in nursing homes. We have seen that the music has been a good non-pharmacological approach for helping older adults who have Alzheimer's or other related dementias by recovering memory and reducing adverse behavioral symptoms. Just wanted to share in case that was helpful for anyone.
And Hannah is 1,000% correct. I think everybody always wants a pill. It's not always the best thing to throw a pill at everything. But as Hannah probably would tell you, they've done research using fMRI studies when they actually put on music, and the brain just lights up like a Christmas tree. So it can be very calming. Music plays a big role. And I'll tell you this, I'm not gonna tell you where it was, but during the social isolation point in quarantine of COVID, some of my patients were having an extreme psychosis, depression, anxiety. So I went to Ole Miss on a piano scholarship. So I got all the patients out into the lobby, and I played hymns for about an hour, and they just absolutely loved it. So Hannah, keep doing what you're doing. It works wonders for patients.
We have a comment from Cheryl. She said using an in-home provider is a great resource when it is difficult to get your loved one to the doctor. So having this contact with Dr. Hutchings is great. Karen asked, will the PowerPoint be available to download for the participants? If you'll send that to me, Dr. Hutchings, if you're willing to share that, I'm happy to get that out to everybody, or a smaller version of it, or however you want to do that.
Yeah, sure. I can send it to you. If you don't mind, shoot me an email for that, and I'll send it to you tomorrow.
Yes, sir. Will do. We have a question from Mary. How do you differentiate between too much lethargy and sleep caused by Alzheimer's versus medication caused symptoms?
Okay, so one thing I would look at the dosages and when the dosages are being given, number one. So I would be looking at, are they on too much medicine or are they on the wrong times for medicines? That if they're getting a lot of it during the day, they may be sleeping a lot during the day. But also pending what stage, we also see sleep-wake cycles disrupted. So every morning I wake up at 4 o'clock in the morning, even on the weekends. But we see in dementia patients that sleep-wake cycles become disrupted. So I would say that even if sleep is disrupted a little bit, as long as they're getting at least 6 to 7 hours of sleep in a 24-hour period, I'm okay with that. So it does change in terms of the sleep-wake cycles. Thank you, Son.
Yeah, I was gonna say you're getting kudos in the chat box.
Thanks.
Does anybody else have any questions or comments? Anything that they would like to share? And full disclosure, Dr. Hutchings, the music program is with the Tennessee Commission on Aging and Disability, which is who I work for. Hannah's a
Okay.
coworker. So I'll be sure to, when I send out the information, I'll share Tennessee Person-Centered Music's information as well. So everybody has access to that if they would like it.
Absolutely.
And with our grant we're doing, it's called Tennessee Minds. So it's the same concept, but it works with caregivers in the home to teach them how to do the music therapy as opposed to what Hannah and them do. They work with residents and nursing facilities. So we're kind of trying to hit it from all angles.
Absolutely. And and if this didn't come across, I'm a very strong Christian, and I pray every day that I wake up one of these days and just don't have a job. And I hope that we'll have this beat one of these days, and we don't have to do these seminars anymore.
I completely agree. I'm the same way. Yeah. Anytime we can get this information out there and hopefully find ways to get this fixed, then we're happy. I'm happy to get any information out there I can.
Absolutely.
All right. Well, if nobody else has anything, I will send you all out the link to do the post evaluation, and then I will get Dr. Hutchings' information out to everyone and our information for person-centered music. Oh, Chris has a question. I'm sorry. Just saw the hand go up.
No, I just put up the clap hand sign because it was an excellent seminar. Thank you so much.
My pleasure, Chris. Thank you for the feedback. Thank you.
Yes, this was great. Thank you so much, Dr. Hutchings. I appreciate it.
My
Would
pleasure.
you repeat the phone number again, please?
Sure. It's 615-340-6840.
Thank you.
Yes, ma'am.
And I'll include that phone number with the email that I send out for everybody as well. So you'll have
Thank
that too.
Thank you so much for an excellent presentation.
My
Yes.
pleasure. My pleasure.
Much agree.
Thank you.
All righty. Thanks, everybody. I hope you have a great day. Thank you, Dr. Hutchings, for taking time for us.
Thank you.
Bye-bye.